Good evening, everyone. Good evening, sir. You are welcome once again.
Dr. Nerat, thank you for having me.
Thank you, sir. I can see we have 20 people already.
Okay. Whenever you give me signal, then we move.
You are welcome, sir.
All right.
So I also welcome everyone for taking time to join the meeting. I can see we have very senior people among us. Thank you for always joining in. We're also happy to have the faculty chairman, National Postgraduate Medical College of Nigeria, also with us. I can see his AI notes. You are welcome, sir.
Chief, good evening, sir.
Okay, so we would like to continue with Rhexis, continuous curvilinear Capsulorrhexis, as Dr. Anya advised yesterday that we still need a session on it. So we'll go right to it. Thank you, sir. You're welcome.
All right, Dr. Nerat, thank you very much. Dr. Batura, thank you. To my seniors who have joined, I consider it an honor to be doing this. Yesterday, or let us say on Saturday last week, we have started scratching on SICS, starting with incisions. Then we completed incision on Monday, if I'm correct. Yesterday, we did Capsulorrhexis yesterday, but it was obvious we needed a lot to be done. So we had asked to complete Capsulorrhexis today. With your kind permission, I will share my screen, but I would like to share a little video I made. Let me share this, please. Okay. Please confirm audio clear, video clear, please. Give me thumbs up. Audio clear, video clear. Let me tap my own. Audio clear. How do you spell clear? Video clear. Let me see if I actually went to school. Correct me if I'm wrong. Audio clear, video clear. I understand it's being recorded for subsequent academic purposes. So it's good to have good video and good audio. All right, I titled this Microscope Camera View versus External Camera View. In my facility, I have a habit of having an external camera recording, while the microscope is automatically also recording. One day, I just decided to juxtapose what happens in anterior Capsulorrhexis, and I was surprised to see what you're going to see also. Let me play this. Let me reduce the volume because the music I added to it. Okay. You could see, it looks like there's so much motion in the eye. But look at the external hand motion. Same surgery, same patient. External hand motion, look at my fulcrum. So for some of us who still have shaky hands, please identify yourself because we are still human beings. For those whose hands no longer shake, we thank God for you. But for some of us whose hands are still shaking, welcome to our world. The external camera view, my support is just a finger. It is not wise to rest all of your hand or support on the forehead of the patient. Now, when you do that, your range of motion or rather range of excursion in and out is limited. But if it is just a finger or two for support, you will discover it will be easier for you to Move from fulcrum to fulcrum. Each time you want to make a motion, it is at the fingers, not even at the wrist, the fingers. And truly, looking closely, it's a combination of a forward thrust and a backward retraction in that seamless motion that will give you both circumferential tear and centripetal pull. Okay, maybe one more play. I like 10 teachers. I like watching every video 10 times. Somehow it sticks in my head. Forgive me, but I won't go 10 teachers this time. Maybe one more time we'll continue Capsulorrhexis. So I found a flap, grabbed it. Oh, it went beyond my control. So instead of doing circumferential, I did more of centripetal. Centrifugal, centrifugal, centrifugal. All right. Pick it up again. Centrifugal, centrifugal. Change fulcrum, centripetal, centripetal. Now, it was difficult to pick that flap. The more I tried, the more I was getting apprehensive. All right, centripetal. Thank you, everybody. Let me pause it. Okay, so this was just a juxtaposition of external camera view of the same rhexis, the same surgery in the same patient, same day, same time. So you might mistakenly think there's so much motion in the eye, but looking externally, you may not even know what I am doing. So for those who are outside, they think I'm doing nothing. But for you watching the microscope view, you might think my hands are shaking. Yes, my hands are shaking. Let me not deny that. But that what makes me a normal human being. All right, thank you. I'll stop sharing this and I'll share another one. The one we used yesterday. Where is my, okay, let's look at this. Go to
anterior central continuous curvilinear capsulorrhexis. So let's discuss this very simple aspect of cataract surgery. It is a very simple and easy procedure. For a seemingly normal rhexis, the following steps may be helpful. Position the globe so that the corneal light reflex is central or near central. Significant deviation of the light reflex probably means that there's some push. Maintain adequate anterior chamber size with viscoelastic solution. Some advocate extra push in of visco to balance the initial push out of visco. Choose your rhexis instrument of comfort. No harm in having a cystotome separate from the forceps. My safe starting point is to make a central puncture of the anterior capsule and direction the puncture towards the 9 o'clock position or any point closer for my comfort. It's good in safety practice to escort the central puncture to only about 1 to 2 millimeters. A forceps is the used to grab the flap of the capsule gently but firmly. You might want to raise the flap just slightly upwards to allow ease of shearing the anterior capsule in a circumferential direction. The anterior chamber must be very well maintained, actually over-filled up at each one time. My preference. The laws of physics do apply. If the initially raised flap is flattened on the capsule to form a sector, it will be easy to notch the sector round the circumference. That is the circumferential pull. If there's an attempt at radial extension, then stop. Fill up the AC with visco. Use a forceps and grab the flap at the base and make a gentle, steady, and opposite clock hour motion until the danger is over. That is the centripetal pull. So a good anterior capsulorrhexis is a seamless blend of both the circumferential and the centripetal forces. Sometimes one might not even notice that both happened. For now, thank you so much, please.
Okay, so this was where we started yesterday. And we said first thing you do is to make a puncture at the center, not the flap you can hold. Advance the flap to a safe perimetry and leave it there. So What is a good rhexis? Starts with this flap that you have raised, turn it over on the capsule, spread it out, let it form a sector. With that, with your cystitum, with your ureter forceps, or with a microforceps, if you keep nudging that sector around, you'll have a uniform capsulorrhexis. That is the circumferential tear. Sometimes the sector that you have formed might unfold. If one continues a circumferential tear when this flap is unfolded, there are chances of radialization. At that moment, one is advised to go for a centripetal pull until any envisaged danger is off or over. The best and the standard motion in capsulorrhexis is to get a flap, flatten it on a capsule, spread it out. Make sure you see a sector forming on you and nudge the sector around. Centripetal pull is more like a rescue mission or a rescue effort. Now, a good capsulorrhexis is a seamless blend of both circumferential, centripetal forces all working together. So let's start watching our videos again. Dr. Nurat, I had requested you put me on notice concerning danger positions or danger points. We'll talk about that today, please. Okay, so everybody will say this is a good rhexis, but I say this is a bad rhexis. Why did I condemn myself? Because the process to achieving this rhexis has to be right and has to be reproducible. If my good rhexis is only by chance, then it is not a good rhexis. The rest of the video is on slow motion so that we can start picking out each step after the other. So the outcome I am told while I was being taught was not what should be our priority. Our priority should be each step of the rhexis. If it is done correctly, then it can be reproduced and also it can be taught to someone else. Let's look at the slow motion of these videos. First step in anterior capsulorrhexis is positioning. Position properly. How properly? The light reflex should be central or very near central. Repressurize the anterior chamber with viscoelastic solution. Dispersive visco is readily available in our environment, but some advocate the double shell technique, whereby one has used dispersive visco and you now use cohesive visco, direct it at the capsule, it will push and disperse further the dispersive visco. In that way, the endothelium is highly coated. We refreshed our minds why we should always, at each one time, overfill the anterior chamber with visco because of the surgical anatomy of the anterior chamber. The average depth of the anterior chamber, the widest position is about 3.5 millimeters, which can range from 2.5 millimeters to as deep as 5 millimeters in a highly myopic eye. So we now said, if my desired perimetry of the rhexis is about 5 millimeters of diameter, it's most likely going to fall into mid-periphery of the cornea. Now, that also means that the surgical depth of the mid-periphery is lower than that of the center. You might be having about 2.5, 2 millimeters of depth, and that will inform your choice of instrument. It's good to have a combination of instruments. If your best instrument is 60 tone, one is advised to cut the knuckle very small. Advised should be less than 1 millimeter. 1 millimeter is easy to mark out, but the system you want to be using, take your time, take it under the microscope, set a caliper, and bend it yourself. The reason is simple. Whenever rhexis is started, there is usually initial loss of visco. Now, when you drop your hands, it's going to depress the posterior lip of the tunnel, so more visco will be lost. When the supporting colibri is putting undue force to the globe, it will dimple, which will also lead to further loss of visco. So what was probably about 2.5 millimeter depth of the peripheral at the point of my perimetry for the rhexis. If I lose visco, I might effectively be having about 1 millimeter depth. And if the knuckle of my cystosome is bent about 1 millimeter, especially if someone did it for me without taking consideration the surgical anatomy of the anterior chamber, I will finish a rhexis, but I would have used the knuckle to nudge around the corneal endothelium. You finish a beautiful surgery, the next day it is corneal striate that you'll be seeing. Not because you did not do well, but because the concept of the surgical anatomy was a little faulty. So at each one time any instrument is going back into the eye, one is advised to reform the anterior chamber and even extra reform it. How do I know I have overfilled the anterior chamber with viscoelastic solution? I have already stained with trypan blue. So I have my blue surface. If I overfill with viscoelastic solution, the iris will retract itself a little further backwards, and I will have the white beyond the blue. So that's always one way of knowing surgically that you have gotten yourself a good depth. And if in the process one notices that viscoelastic solution is being lost, please stop and reform the anterior chamber. Now, you will notice that I've spent about 3 to 4, 5 minutes talking about visco. Why? Because success or failure is visco, not the instrument. Success or failure of rhexis is a viscoelastic solution. It's a repressurized anterior chamber. Any instrument of choice can also go. Utotal forceps, if you want to advance it yourself. Microforceps, if you have access to such. Then the next thing you do is to titrate your hold. My support using the colibri, I think this was I think this support was not safe enough. So please, score me here -5, please. Deduct mark here -5. This is not, I was fighting the eyeball. I was not doing surgery. Then let me see how I entered and the initial loss and for continued loss. If initial loss, yes. If continued loss, no, stop, please. All right, let me play back the video. Locate the center. Achieve a puncture as soon as possible. Great. Don't go to periphery to achieve a puncture. Nudge a flap out that you can hold firmly. This is where, let me make my confession. This is where adrenaline starts surging on me. This is where adrenaline starts surging on me when I am holding firmly. Now I hold firmly and I look at adrenaline to my right or to my left. Where are you, adrenaline? Could you just please stop disturbing me? Let me do this work. And somehow adrenaline listens to me, starts pumping, and I do my work. So if you're like me also, adrenaline starts pumping up on you, please turn around to the left or to the right, locate the adrenaline and give the adrenaline a warning. Tell adrenaline to leave you alone, that you are a surgeon and you're going to do a beautiful surgery in this eye. So make a puncture, nudge out a flap that is visible enough for you to hold firmly, grab the flap, confirm it is firmly held up in your instrument, and advance it to the desired perimetry before one starts circumferential pull. So I've reached my desired perimetry, then I'll stop. All right. Did you notice I'm losing visco? I am losing visco. My attention is there. All right, so I've gotten my sector, but it unfolded on me. That was why we said when you are told to stop, okay, how do you stop to re-continue? Stop means if you are doing centripetal motion, stop the centripetal motion. If you are doing circumferential tear, stop the circumferential tear. But most importantly also, free the instrument from the flap. Because at that point, if your instrument is coming out through the main incision, there will be inadvertent tear that you did not intend placing on the eye. In this case, I was lucky it didn't go radialization. So it looks like it was part of the program, but it was not. So what you should do is target the opposite clock hour. Move your instrument towards the opposite clock hour. The flap will leave your instrument safely and conveniently. Then you can now go back to the base and regrab it. Now, we also introduce the concept of pi r squared. That also means whenever the radius, which is your flap, is getting longer, the circumference will be wider. That means, as the teaching says, follow 2 clock hours at a time. Because at each one time, the first clock hour, the second clock hour, it will still give you a short radius, which means the length of flap is still sizable enough or normal enough to give you the desired circumference. And each flap has a base. If I had done 2 clock hours and I stopped, there is no wisdom in going back to pick the tip of the flap because I will only continue the radius. And the law of physics is still pi r squared. So if I'm going to regrab any flap, I go to the base of the flap and regrab it. So let's go ahead. Okay, Dr. Nurat, let me show you something here while I was saying difficult positions. Because of the incision that was made, please, could you see my cursor? If you can see my cursor, give me a thumbs up, please. I'm moving my cursor. If you can see my cursor, give me a thumbs up, please. I'm waiting for thumbs up. Okay, if you can see my cursor, thumbs up. Confirm that my cursor is visible to you. All right, I want to explain difficult areas in capsulorrhexis. Now, this incision definitely has a nasal margin and a temporal margin. I have introduced my instrument and unfortunately or fortunately, my fulcrum is wrongly positioned. This is the lateral margin of the incision, and I am working on the lateral half of the eyeball. That means my fulcrum effect is wrong. My instrument should have hinged on the nasal margin so that I can have freedom to move my instrument here and here. Because I wrongly hinged my instrument on this wrong fulcrum, because it is lateral margin while working on the nasal margin, I'm moving the eyeball to my what? This should be left. And to bring it back to position, I am pushing my second instrument inwards to position or reposition the eyeball into place. In the process, I'm losing more visco because I'm compressing the eyeball. So this fulcrum effect is wrong. I should have hinged my instrument here. Forgive me, some of us that have, are a little scared. I was scared also. Now, if I had done it properly, I would have hinged my fulcrum here and walked on the lateral half of the eye. When I'm walking on the medial half of the eye this other way, I hinge my fulcrum here. That is what's called a fulcrum effect. All right, so the difficult areas, because this is projected some millimeters into the stroma before entering into the intracameral space, this has already given you an edge that is not at the limbus. So you cannot freely move your instrument in and out in any direction you want. That also means to pick a flap at 1 o'clock position here and pick a flap at 2 o'clock position here will be difficult. Why? You'll be pushing the eyeball out of position while your second instrument, which is the holding forceps, is trying to reposition it back into position, and you will compress the eyeball, you will lose visco, and the rexis will radialize immediately. So these are the difficult positions to regrab a flap. 2 clock hours before the incision margin in one direction, 2 clock hours after the incision margin in the other direction. Those are the difficult positions. So if you're planning to do a regrab, start at 3 o'clock position. So 3 clock hours before either the nasal or temporal edge of the incision. If you want to regrab again, go 3 clock hours. That means if I pick it here, if I pick at 3 clock hours here, I will not drop it until I cross over here. Even if I want to drop, the best place to drop is exactly 12 o'clock, which is in front of me, such that when I want to regrab, I'll repressurize the eyeball with viscoelastic solution. And this flap, the base of the flap is directly in front of me. So this is 3 clock hours motion to 12 o'clock position. If I choose to stop it, I can drop my flap here and grab it from here. Or I will escort it to somewhere safe 3 clock hours from the margin of the incision. Dr. Norat, are you with me?
Yes, sir.
It looks like the house. Okay, I think it rained. The weather is cold. So let's do this way. If you are hearing me and you're okay with what I've done so far, please could you just give me some thumbs up? Let me know if the danger positions in SICS in CCC has been taken care of. If you think we should revisit the danger positions, also you can say yes. Okay. Thank you, everybody. Oh, we should revisit. Okay, no problem. We have all time. We have all year to revisit. Okay, so let's play this and continue. So I move it to where I can see it. The flap is getting longer. Pi r squared. Then I stop where I can easily pick it back. Oh, I went across. All right, this is actually what it should be, but it's wrong. Don't have a longer flap. Always remember pi r squared. So this is centripetal, 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 centripetal. So a good capsulorrhexis, only you, the surgeon, should know when you switch from circumferential to centripetal. It is a seamless blend. All you are looking at, yesterday we talked about area of attention in rhexis, and I said the area of attention in rhexis is at the point of the sharing. at the point of the rhexis. Let's look at this, okay? Take a puncture as soon as it is possible. This took longer. All right, but now this is risky I did here. Don't leave a long flap. See what happened to me here. All right, so this is not my desired perimetry. It was going on itself. So I now started using more centripetal work. When you achieve a puncture, just raise the flap, a short one, so that you'll be in charge, and move the flap of the capsule in your desired direction to your desired perimeter, please. I'm arriving at the difficult areas to the graph, so I'm freeing the flap from my instrument. This is a better axis. All right. I went back to the base. This one, my fulcrum effect is good. Excellent fulcrum effect. So I continued circumferential, 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 while watching the point of tearing. Centripetal, 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 centripetal. So this is a good rhexis, not because of the outcome, but because of the process I followed. Let me play this back again, please, if you don't mind. If you don't mind, please. The reason why I say we should play back again because of this. Okay. This is why I say we should play back. Yeah, this is wrong. I raised the flap. I continued nudging the flap to the periphery for a longer millimeter. That was why it put me into that trouble. I would have just raised the flap, made probably 1, 2, maximum 3 millimeters, and then guided myself. So I allowed it to continue going by itself. And it went to an undesired perimetry, put me in a tight corner, and I started struggling to come out of it. Centripetal, 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 centripetal. All right, back to circumferential. I left it. I made sure there was no flap anchoring on my instrument because any motion of the instrument, it will tear beyond my intention. So I picked at the base or near the base, circumferential, circumferential, circumferential. I'm just looking at the circle that is forming, the tearing that is forming, circumferential, 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 and I want to stop because I'm moving to the difficult point of rhexis. All right, free my instrument. Okay, thank you. My fulcrum effect is good. How do I know my fulcrum effect is good? I'm not pushing my second instrument too deep into the eyeball because there's no need to reposition the eyeball. Eyeball was not being moved at me. I switch over to centripetal immediately. So it's seamless. It shouldn't be documented circumferential, oh, I have switched over to centripetal. No, it should be seamless blend. All right, thank you. Maybe we should look at the next video. This was why I said I rendered an apology to the residents. I used to give my residents white cataracts to go and operate. I don't think I'll do it again. It's not wise. A resident will learn better with a good cataract, not a white one, because of the fear of Argentina flag. I've reached my desired perimetry. I have stopped. Went back to the base, picked it up. All right, circumferential, 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 circumferential. Release. You saw what happened because I did not release that capsule properly. Now it has taken me to difficult zone of rhexis. Centripetal, centripetal, circumferential, 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 centripetal, centripetal, centripetal. In centripetal, direction of pull is towards the opposite clock hour. Okay. This is a slow motion of what I just did now. Watch visco come out. Yes, it does come out. Is it continuously coming out? I think so, but slowly. To stop it from coming out continuously, lift your hand up so that the anterior part of the tunnel will pull the posterior tunnel up. Any visco will go underneath it and get trapped there. My second instrument is not putting any undue force on the eyeball. So I'm not losing visco. Visco is still coming out slowly. I can see that. But it's safe enough to continue. This is where I got it wrong. I should have freed that flap completely. Then go back to the base. Fulcrum effect. No, bad fulcrum effect. So you can see the bad fulcrum effect causing me to lose visco. You could see that. And I did centripetal at that point because the anterior chamber showed me some level of shallowness. So in all of these capsulorrhexis, you are still the surgeon. So you make your surgical decision at the moment. So if your decision is to do centripetal pull, you are right. If your decision is to do circumferential tear, you're right. But where will you be wrong? If the anterior chamber is shallow, your decisions will be faulted anywhere. But if anterior chamber is well formed, the flap is not dancing around your instrument, then whatever decision you take, I will support you. You're right. So I'm looking at the tear. Apparently, okay, the instrument leaves the flap. Beautiful. I noticed shallow AC. I have to repressurize. Visco is cheaper than corneal endothelium. Look at my desired perimetry for the rhexis. That coincides with a shallower part of the anterior chamber. So the knuckle of my instrument can be destroying the endothelium as I am going round. This video will be made available to us, or I could send a link to the YouTube page where I posted it. I think it's about 4.5 gigabytes, so I might not be able to share it across WhatsApp, but I can send a YouTube link for those who want to have access to them. I think there are so many other videos too like that. So I'm now escorting circumferentially so I can achieve a 6 millimeter rhexis. All right. So I'm going to leave my instrument, but going opposite clock hour. Any movement of the flap will continue tearing, whether you know it or not. It's irrelevant. Just make sure that the instrument is free of any flap tagging along it. Repressurize, achieve very deep anterior chamber. I want my flap upon a capsule to give me a sector. That was why I did that approach. Right. So if I might ask a question now, let me ask this question. If you were the one to finish up these rhexis, would you do circumferential tear or centripetal pull? That's towards the center. Let me have your opinion on the chat box. Circumferential or centipede. Second, I'll take it as circumferential. Centipede, I'll take it as centripetal. Please chat with me. Nura, let me start with you, please. If you were to complete this now, what will you do? Let's be practical, please.
Centripetal.
Centripetal, centripetal, centripetal. Oh, great, great. And centripetal means what? To the center.
Yes,
It's the
sir.
law of physics now, to the center. So this is what clock hour approximately. Remember, the surgeon's position is considered 12 o'clock position. So I started with the side port. The side port has automatically become the surgical 12 o'clock until I take it back to my main incision. So this is 12 o'clock position. So I'm probably around 4 o'clock position. And because it's an awkward position for me, then I have to pick it up and go centripetal. 4 o'clock position across it is 10 o'clock position. So my angle of motion will be towards 10 o'clock position. Right? Let me see what I did. Hope I'm not lying to all of you here. But to the best of my knowledge, at this point, watching this video, I would say the surgeon should do centripetal. Pull it toward the light reflex, across it to the opposite clock hour. Let me see what I did. Picked at the base. Just hold on, calm down, don't be calming down. Okay, what did I do? I did circumferential. It is now I'm doing centripetal. All right, all right, all right, all right. Whichever I did, I was looking at the tear as it's coming. If the tear is going haywire, I pull out. If it is going as planned, I continue circumferential. If it is going haywire, I pull out. If it's going as planned, I continue circumferential. Even when I started pulling towards the center, I was looking at it as it was tearing. If the tear becomes beyond me, I'll just go a sharp pull towards the center. Just a sharp pull, and it will be rescued back. Wow. Thank you, everybody. I think so far we have talked about Capsulorrhexis. I don't know if it is safe enough to say any question at this point. I don't even mind if we can take another day and discuss Capsulorrhexis, please. Thank you very much. Dr. Bature, I yield back to the house.
Thank you very much, sir.
God bless you.
So do we have questions, clarifications that I would like to make? Okay, somebody's asking a question already. How do you do a CCC with a calcified anterior capsule?
Question is, how calcified? If the calcification is localized, then you can share it out with a centripetal force. If the calcification is going to compromise the integrity of the capsule, I will introduce a micro scissors and share it out from there with the scissors. If I have a larger area of calcification, I'll use my keraton and make a 4-position entry, 12, 6, 3, 9 o'clock positions, and use scissors and go around through those paracentesis I made, and then have my rhexis. All you're trying to do, just to bear in mind, that any calcification of the capsule is not just about the capsule. The zonus might be involved. Any cataract that has such calcification, the person probably has poor vision on that side, must have been hitting the head here and there. So expect a bigger problem. So the calcification should be a pointer to a bigger problem. So me, I'll be more scared of the zonus than does the capsule. Like I said, if the calcification is a smaller area and I can release it with a centripetal pull, maybe the person is asking if there can be any circumferential pull. I'm not sure any surgeon will advise you on that. It depends on what you are seeing, but calcification is just like it's difficult to share. So you just pull to the center and it tears off. Now, but if you know, or by your judgment at that moment, that the zonals will be affected, please use scissors and overcome the calcified area. If you have a larger area that is calcified, please pick your keraton and make 4-point paracentesis, 12, 6, 3, 9. Go with micro scissors and go around it and then achieve your rhexis. That's the much I can say about that. I only know that whatever the eye presents on table will determine what to do. Someone asks, how do you enlarge a small rhexis? I think I have a video on that, please. Can we do that video tomorrow? Dr. Nurat, are you there?
Yes, sir. It's fine, sir.
If I have the permission, we'll discuss white rhexis on a white cataract. I think there were some, I had Argentina flag sign. If I can locate one, then we'll discuss that tomorrow. How you can enlarge small rhexis. You can primarily decide to do a double rhexis, or you can continue with what is called a spiral rhexis. Double rhexis is planned by the surgeon. A spiral rhexis is where you anticipate danger and initially went ahead for a small rhexis, only to discover that the danger was overrated. You can now continue as spiral rhexis. I'm not sure anybody initially will just go out to go and do spiral rhexis. Usually, most times, is the danger you anticipated was just overrated. So you can now continue as a spiral rhexis. And also spiral rhexis, if you misjudged your lens of pacification classification, and suddenly you discover that this nucleus is denser than you had planned, you can, instead of doing 5mm rhexis in diameter, you can now do spiral rhexis to continue as a 6mm rhexis. So you can do a double rhexis as planned primarily, or you can do a spiral rhexis if the danger you anticipated was overrated. Okay, 4-point, no, I said 4-point paracentesis, so that I can use micro scissors or any capsular scissors to, through those 4 positions, 3 o'clock position, 12 o'clock position, 9 o'clock position, and 6 o'clock position. I will have access to them and then use scissors to cut a large, widespread calcified capsule. Because if you start struggling with a calcified capsule where it is widespread, you might lose the zonular integrity. And that is solving one problem and creating another. Okay? Any further question, please?
Yes, sir. There are still other questions. Please explain how to bend the needle for rhexis. Can you kindly explain again, sir?
We have our bent needles already. We have our bent needles already. I will understand that for our rhexis. But take it back to the microscope, if possible. Take out to higher magnification, times 16. Get your caliper and measure out 0.5. Then put it at the tip. Some surgeons, I have seen them use a mark, put a mark on their metal uteter forceps, just to map out 5mm for diameter. Some will map out 2.5 forward, 2.5 backwards towards themselves. So you can actually dedicate a cystitome and carefully nudge it so that the knuckle will be very short. The reason is simple. If you are advancing your rhexis to a 6mm perimetry, remember, the surgical anatomy and the depth there is very small. And if you're losing visco alongside, you might actually be rubbing the knuckle on the endothelium. It's just a safety measure, please.
Okay, thank you, sir. I think you've answered all the questions. Are there any more questions?
Maybe I should ask my own question.
Okay, because there are no other questions here.
Who amongst us here will do can opener tomorrow in theater? No, we are surgeons. Let's be sincere. Who amongst us will do can opener ever again from tomorrow? Nora to laughed. So there's a chance that you might do can opener tomorrow. Prove me wrong. Dr. Mustafa.
I won't do can opener.
The question is why? And why not? After all, it's a recommended approach to capsulorrhexis. The question is why not? If you won't do it, why not? If you not do it, why? Let's talk like surgeons. There's no pass or failure here. Okay, someone says if there's no trypan blue, that it's almost a given. You should do can opener. But if your microscope has retroillumination in a non-white cataract, you can as well try your distance, your rhexis. Funny enough, even in a white cataract, you can still do without trypan blue. I think, and I know that trypan blue is very cheap. If the hospital system is not helping us, maybe we should help ourselves to procure our own trypan blue. Now, I was discussing with Mustafa and I shared a concern with him. Every surgeon, because cataract surgery is more like for every ophthalmologist before we start diversifying. What if you have to put your capsular tension ring? How will you put it with a can opener? Someone asked about calcified capsule, and I said calcification of the capsule is a pointer. It's not just a problem, it's a pointer to so many problems in the eye. You might have weak zones, and you need to put a capsular tension segment. How will you do that if you don't have a good view of your capsular margin? We are in a century where artificial intelligence is threatening everything we know. Very soon, robotics will come into eye surgery. How shall we be talking about can opener? Have you noticed that the recent American Academy series, they no longer talk about can opener? So the world is moving out ahead of us. And I have to give credit to our teachers. They have done their part. The ball is not in our court. Of course, they have to still supervise us until when they think we are safe enough to handle ourselves. But for now, the ball is in our court. We have to show them that they did not invest in us for nothing. Trust me. Look at it this way. Why will you have to go back to learn a step of surgery that you should have learned in the first place? It also means that you will cut your curriculum short in other areas of surgery, only for you to apply to management, to go back to one training in Ghana, in India, wherever, to go and learn what you should have learned in the first place. Because if you open a textbook, ask ChatGPT to give you steps of cataract surgery, they will mention this. They will never say can opener. And the question is, why 10 teachers? Because myself, I think I have myself to blame also. I used to blame my teachers. I used to blame the hospital system. I used to blame ASU for going on strike. I used to blame resident doctors for going on strike. I used to blame NMA for going on strike. And I'll tell myself, nobody is teaching me. Until it dawned on me that it's not true. All our teachers, as I speak, every one of them that pick phone to send a message to me or to call me, they're always asking me, how have you fared? And I'm like, even after all these years, these people are still checking up on me. Each time I call Mustafa, I don't call him to say hi to him. I ask him, because how are you faring? Because that's what my teachers keep asking me. The truth is this, our teachers have paid their price. But the question is, what are we actually doing? That's why I came up with 10 teachers. 10 teachers simply means at least minimum of 10 people are teaching you at each one time. Approach them respectfully and then tell them of your intention to be mentored by them. Request for their materials, documented materials, recorded materials in audio or visual, and go through it. Part of 10 teachers, which we'll do, if I'm permitted, on last day is to teach us how to acquire videos from the internet and how to edit surgical videos. Areas of interest, you see me zooming on areas of interest. You see me slowing down on certain places because I am teaching myself. This video was not made to teach anybody. I made it to teach myself. It's only a coincidence I'm sharing with people. I have videos on retina. I have videos on, okay, I don't have an oculoplastic because I don't like oculoplastic. So I have videos on retina, I have videos on glaucoma. My glaucoma ab internal, first one I did, nobody taught me that. I did it on 10 teachers. What am I trying to say? We can teach ourselves, we can help ourselves. Whatever challenges our teaching hospitals have, it is universal. For example, you might likely not find yourself using one blade per patient. You can buy your own and put in your pocket. Our teaching hospitals struggle to meet up accreditation. They will go and conjure here and there to get to a wet lab. I tell my residents, go get a wet lab and put it in your house. Put a wet lab in your house. I don't have a microscope. Yes, we know microscope is expensive, but a trial frame is not expensive. Take up a trial frame, go and pick +3, +2, or +2.5 and put there. All you need is magnification. Let your spouse or whoever you stay with or your kids, let them hold torchlight for you. Let them be part of your training. Then start all the suturing techniques. Go click on Google, all suturing techniques. What is mattress suturing? Click on it to show you. Then practice it on yourself. By the time you go back to the hospital the next day, what was just mentioned verbally, you have already downloaded the videos. You have already done 10 teachers on the videos and you're already teaching it. That is the whole principles of 10 teachers of teaching yourself ophthalmic surgeries. Wow, Dr. Nurat, thank you for having me. I don't know which one we're going to do tomorrow. Maybe we should dabble into nucleus management, or we can look at difficulties or more difficult cases in SICS. I'm sorry, in CCC.
Okay,
All right.
and then the double Rexis that you mentioned. Now you'd like to show us a video.
I have enough video of that, so I can always reach out for the videos. Then Argentina flag, I'll look at one that has Argentina flag, so we can look at it. Okay, so CCC tomorrow. That's what it means. Am I correct?
Maybe half the time, and then we can move to something else. Or what do you think, sir?
No. When I do 10 teachers, I dedicate 2 days for each step of cataract surgery. Because after the second day, you will still see need on the third day to continue discussing CCC. Actually, if we start discussing CCC for the 1 week, you will still discover on the last day, there's something you will learn afresh. And true confession,
Yes,
I just learned something now while discussing this Rexis now. Because I made this video to teach myself. Okay,
right,
maybe we can do what do I call it now? Surgery video editing tomorrow, if that's okay. Do CCC and then do surgery video editing.
That's fine, sir.
All right.
Okay.
Thank you. Let me stop sharing.
Sorry, sir, why not we take the nucleus management before the video editing?
Oh, great.
It's just a suggestion, actually. Yeah.
Well, I am under authority if you
No, sir. Hydro dissection.
Okay, let's do nucleus management and
some difficult Rexis, yeah.
If we start Okay, what I used to do is this. I have a particular video that I had a collection of difficult rexes. So from there, we can now move it into nucleus management. So if it's okay by you, we'll start from difficult rexes and then go into nucleus management.
Okay, that's fine. Thank you so much. Yeah.
Please. God bless you all.
All right. Thank you, everyone. It's been a wonderful night. Thank you, sir. And we'll meet tomorrow, same time, 8 p.m. for another